Hello, I'm Ben Johnson. John Engel asked me to do this DVD on the profile rotary nickel titanium instruments for inclusion in the new edition of his textbook, and I'm more than happy to do so. Profile were the first rotary nickel titanium instruments of greater than O2 taper introduced to the profession in the spring of 1994. I want to advise you that this discussion is by no means a substitute for reading the instruction booklet. It's merely an attempt by me to familiarize you with the profile system and how it interplays with previous hand instrumentation and subsequent introduction of other nickel titanium systems. Prior to the introduction of rotary nickel titanium instruments, most clinicians divided the root canal system into basically three parts: coronal, mid-root, and apical third. We generally utilize different instruments in these three different areas. We quite often started our procedure by locating the apical constriction, or the working length of the root canal system, with an appropriate size file and determined the working length. This was accomplished initially. Then we use larger instruments in a watch-winding motion or reaming action, or perhaps circumferential filing motion to enlarge the canal apically a size or two, and some circumferential filing to open up the coronal portion of the root canal. You will notice on the video that with a circumferential filing motion that the tip of the file always cuts on the outside of the curve. As you insert the file and withdraw the file, the blade cuts on the inner portion of the root canal. You will also notice, with rapid repetition with this circumferential filing motion, that you have as much propensity for pushing debris apically as you do for removing debris from the root canal system. After enlarging the apex a size or two, we generally used Gates-Glidden drills in the coronal area to open up the canal down to the first curvature encountered, which usually was not very deep into the canal. I started with a number 3 to give me a little penetration in the orifice, followed by a number 4 to flare the orifice considerably, and then let a number 2 go into the canal to the depth that was appropriate, or until I met resistance. And of course, you always irrigate after each instrument. Since the working length was determined and the coronal area flared, we could concentrate on the apical portion of the canal system. We generally check for patency after each instrument in order to bring debris into suspension and to make sure we haven't blocked ourselves out of the canal. Now we can go to a larger size file, and again with a watch-winding action, reaming action, balance forces technique, and/or circumferential filing could enlarge the canal further. Now you notice that a standard O2 taper file, be it stainless steel or nickel titanium, always cuts with the tip of the instrument first, and generally the tip is cutting on the outside of the curvature. With the balance forces technique, a technique introduced by Jim Rohn, you will notice very little debris is pushed apically. Again, check for patency. The file is as centered as it can possibly be. The instrument always cuts on the outside of the curve first. Check your apical stop again, and you will notice debris forced out of the apical opening. This is basically the way we have instrumented canals for decades. Now this is a K-type file on the top with a sharp, aggressive cutting tip, sharp transition angle, and sharp edges. Historically, files were either twisted or ground out of stainless steel in either triangular or square blanks. Initially, all files were square, but in the later years, in the 70s and 80s, the determination between a reamer and a file was basically how many spirals it had, not its cross-sectional configuration. Two things are important to note on this scanning electron micrograph. Number one, the K-type file had sharp transitional angles. Number two, sharp edges. Either would result in transportation of the root canal. Improvements in the design were made by Jim Rohn in the early 1980s, where he put a second angle that merged the tip with the blade of the instrument, and that decreased the transitional angle. This enabled the file to stay centered in the root canal easier with rotational forces that he popularized as the balance force technique. Frank Wine, in articles and lectures in the early 70s, advocated dulling the flutes on the outside of the curve to keep the instrument from transporting with a circumferential filing motion. You will see with the introduction of the profile that I implemented both of those designs in that the profile tip is bullet-shaped, with a smooth transition from the tip to the blade itself, which no longer had sharp edges, but has radial lands replacing them, which you could say are dull, and it cuts only in a rotation motion, not in a circumferential filing motion. Additionally, I increased the taper of the instrument from your ISO standard of a .02 taper to a .04 taper in our first instrument. We later introduced 06 tapers and orifice shapers. You can see the tip of the file doesn't cut at all in a standard canal. Only when the increased taper up the blade starts to encounter dentin does it actually cut, and when the full blade starts to cut, then it ceases to move apically. The resistance to apical penetration is telling you to either change your size or the taper of your instrument. Initially, the blades were made to where the center core of the instrument was pretty much parallel, so if you overstress the instrument with torque, the instrument would unwind as opposed to separate. Clinicians complained about this unwinding, so the grooves were not cut as deeply up the shaft, which gave it more torque strength. It will still unwind, generally speaking, prior to separation once you exceed the torque limit. Separation is a perceived problem, which initially was the greatest resistance to nickel titanium, along with the cost of the instrument. North Carolina, in a study with their undergraduate students, pointed out that instrument separation, when the operator is trained in the technique, is no greater than it is with hand stainless steel files. In fact, while performing cases in the clinic, the students did over 400 cases. As you can see, they had 6 stainless steel instruments separate, 2 rotary 06 taper profiles, and 2 hand 04 taper profiles separate. So separation of nickel titanium really is no different than separation with hand stainless steel instruments. Why did North Carolina change to the profile system? Well, for several reasons. One, it allowed their students to treat more complicated cases. It reduced the procedural errors encountered during endodontics, such as blocking yourself out of the root canal, perforation, and/or transportation, and it reduced the technique sensitivity of cleaning and shaping a root canal. In other words, the students were more predictably able to negotiate the root canal system. Here is a lower second molar treated by an undergraduate student, and I think you will agree he developed a tapering frontal form preparation from orifice to apex and did this with ease, without transportation or other procedural errors encountered. The University of Tennessee was one of the first dental schools to implement the use of nickel titanium instruments in their undergraduate classes. This graph looks very complicated, but indeed it is not. On the left are the cases done by the students of the calendar year 94 and 95, and you will see that they did over 500 cases. The column to the left is the number of appointments that it took the students to complete these cases. You will see that 26% of the cases required 4 or more appointments. However, this was an improvement over hand stainless steel instruments. Remember, they were dental students who were new to endodontics. When they switched from hand nickel titanium to rotary nickel titanium in calendar years 1997 and 98, you will notice that the number of cases that required 4 or more appointments dropped to only 10%, and in fact, the cases they were able to complete in one visit almost doubled. This is again pointing out that the students were able to treat these teeth without procedural errors and with more efficiency than they were able to do, particularly with hand instrumentation with stainless steel. Before we get into the use of the profile system and how it fits into the scheme of cleaning and shaping with the other instruments that are available in the marketplace, I want to talk to you for a few moments about separation. There are 2 reasons that an instrument separates. One is excessive torque above the limit designed of the instrument, and the other one is cyclic fatigue, or metal fatigue of the instruments. Torque, easily demonstrated here. When the torque limits of the instrument are exceeded, the instrument will unwind and deform, and if you do not relieve the pressure and continue to rotate the instrument, it will be followed by separation. All things remaining equal, if you decrease the lubrication in the root canal system, torque will increase because of the increased friction of the instrument against the tooth structure. If you increase the pressure on the instrument, this will increase the torque, all other factors remaining the same. In fact, excessive pressure is probably the single greatest reason for instrument separation. If you increase curvature of the root canal system, this will increase torque, because the instrument shape memory wants it to remain straight when it is forced to rotate around a curve. This induces drag with the instrument and tooth structure and will increase torque. If you increase the surface area of the instrument in contact with dentin, this will increase torque. You can increase the surface area in contact with dentin by 2 ways. One, by using a larger instrument, either larger in diameter or larger in taper, or by using the same instrument deeper in the root canal system. Whichever way, the increase in the surface area of contact of the instrument with dentin will lead to an increase in torque. If you decrease the RPM of the instrument and you maintain the same curvature, surface area, and pressure, the instrument rotating at a slower speed will take larger and larger cuts, and this will increase torque. If it is rotating at a higher RPM, it will take smaller cuts into the dentin, and this leads to reduction in torque exerted on the instrument. Now, looking at these things, you can understand that as you go deeper within the root canal system, curvature is more than likely increasing. The amount of surface area of the instrument in contact with tooth structure is increasing. So the deeper you go into the root canal system, if you want the torque to remain the same, you should decrease the pressure exerted on the instrument to minimize separation. Cyclic fatigue is merely the fatigue introduced into the metal as it is forced to rotate around a curve. With every rotation, the surface of the instrument is put under a compressive load on the inside of the curve and a tensile or stretching load on the outside of the curvature, and with every rotation, this occurs on all the surfaces of the instrument. Cyclic fatigue will not occur on an instrument in a straight canal. The first thing that affects cyclic fatigue is curvature, all other things remaining the same. If you increase the curvature that the instrument is forced to go around, this will increase cyclic fatigue. If you decrease the radius of the curve, this dramatically increases cyclic fatigue. Here you have 2 90-degree angles. The one on the left is the long radius curve, and the one on the right is the short radius curve. The short radius curve induces much more cyclic fatigue on the instrument than the longer radius curve. If you increase the diameter of the instrument, this increases the mass of metal. The more mass of metal, the faster cyclic fatigue builds up as it is forced to rotate around the curvature. And similarly, as you increase the taper of the instrument, this results in an increased diameter as you go up the shaft compared to a smaller taper. So increasing the taper of the instrument will increase cyclic fatigue. If you increase the number of forward and reverse cycles on torque-controlled handpieces, this will introduce a longitudinal cyclic fatigue in the depth of the flutes. Torque-controlled motors should be used as a guide to teach you the proper amount of pressure. If you encounter a reversing action, this is telling you that you are putting too much pressure on the instrument. If you keep that same amount of pressure, this will continue to go through these forward and reverse cycles, which is winding and unwinding the blades of the instrument. This introduces cyclic fatigue forces in a longitudinal manner on the instrument, and this will greatly decrease the resistance to cyclic fatigue of that particular instrument. Now, looking at these things cumulative, you can tell that if you are dealing with a relatively straight canal, cyclic fatigue is not your problem. In fact, it is not your problem on mild curvature canals. It only becomes a problem with moderate and severe curvature. So if you are trying to select an instrument to prepare a certain canal, if it's relatively straight or minor curvature, select an instrument that has high torque strength because cyclic fatigue is not a problem. On the other hand, if you're dealing with a moderate curvature, which most endodontists deal with, moderate and severe curvature, cyclic fatigue does become a problem, and the selection of instruments should be one that has high resistance to cyclic fatigue, such as in severe curvature, an 02 or 04 taper, or moderate curvature, an 04 or an 06 taper, versus 08 or 0.10 tapers. So keep these things in mind, or perhaps you would want to utilize a very flexible instrument, because the more flexible an instrument is, basically the more resistant to cyclic fatigue it is. Conversely, it does not have very much torque strength. Now, I classify instruments, rotary nickel titanium instruments, into their method of cutting. I divide them into active cutting blades and passive cutting blades. An active cutting blade, when you put it into a plastic block or canal and rotate it with no apical pressure, will pull itself into the root canal, and as you can see, will actively cut the dentin with no apical pressure. The instruments on the market in the United States are Liberator, Flexmaster, Race, Hero, ProTaper, and Sequence. The other category of instruments are the passive instruments. When you put a passive instrument into a plastic block or a canal and rotate it with no apical pressure, it basically does nothing. It does not pull itself into the canal, and it does not cut. It takes a little apical pressure in order to cause these radial lands to engage dentin and cut. The major instruments in the marketplace in the United States with passive blades are Profile, Lightspeed, GT Instruments by Dr. Buchanan, and the K3 Instruments. This is a computer CT reconstruction of a tooth with moderate curvature in the mesial canal of a lower molar. This is the preoperative slice in this area of the root prior to instrumentation. You can see the canals and you can see the isthmus between them. This is the post-instrumentation slice. On the right-hand side is the canal performed with a passive cutting blade. On the left is a canal performed by an active cutting blade. It's irrelevant as to the manufacturer of the instruments. You will see the same thing regardless, because the in and out motion exerted on an active cutting blade will allow the blade to continually cut on the inside of that curvature in this portion of the root. If it were apically, it would allow it to cut on the outside portion, basically straightening the canal. Here is the overlay of the pre- and post-instrumentation. Let's look at the instruments on the market as far as flexibility. The most flexible instruments in the marketplace are generally the triangular instruments of one iteration or another. This one happens to be a cross-section of a race file marketed by Brasseler. This type of blade configuration has the least cross-sectional area of all the instruments in the marketplace. Therefore, it is the most flexible, resistant to cyclic fatigue, does not have a great deal of torque strength, but in severe curvatures would be an appropriate instrument for use. In cross-section, this is a ProTaper instrument, which you can see is a convex triangle. It has a large mass of metal in cross-section, relatively inflexible, particularly in the finishing instruments, which have the larger sizes, large mass of metal, lot of torque strength, not very resistant to cyclic fatigue, would be very appropriate in straight canals or canals with slight to moderate curvature. In between these two extremes lies the profile system, and you can see in cross-sectional area it certainly has more than the basic triangle, but considerably less than the ProTaper previously demonstrated. It also has considerably less cross-sectional area than the K3, slightly less cross-sectional area than the GT files by Buchanan. In other words, it is the most flexible of the passive cutting blades, with adequate torque strength and adequate resistance to cyclic fatigue. If you wanted a stronger torque instrument than this, but preferred a passive cutting blade, you could of course use K3, or you could use a greater taper instrument, or you could use a larger taper of the profile systems. The greatest advantage of the profile system compared to other passive systems is it has a multitude of apical sizes and comes in either hand Series 29 sizing that Dr. Schilder popularized in the early 90s, or ISO sizes from size 15 up to size 80, and comes in 04 and 06 tapers. Here you see a blade that's cross-sectioned at different areas. The one on the right is closer to the tip. That gives it more surface area. As you get closer to the tip, the grooves are not cut quite as deeply. This gives you more torque strength in the smaller diameter at the tip. As you come up the blade, a little deeper cut gives you more flexibility as you are coming up the shaft, maintaining adequate torque strength of the instrument throughout the working length. Now, I've been talking to you about passive and active cutting blades. Let me give you a demonstration. This is a plastic block with an S curvature. The manufacturer, Dentsply Tulsa Dental Specialties, recommends starting your canal preparation with the orifice shapers. This one is a 40 orifice shaper, which would be appropriate for that canal size, followed by a 30 orifice shaper, giving you this crown down preparation. Then, with the introduction of the 2506 taper, taking it until you meet resistance to penetration, followed by a 2504 taper, each insertion deeper than the previous. This is important in rotary nickel titanium. Each insertion should be deeper than the previous, and repeated returns to the working length are inappropriate and unnecessary. But in the passive cutting blades, you can do it with impunity without transporting the root canal system. Enlarging the preparation to a 2506, which I think is about as large a preparation as I would want to do around this multiple curvature, and you can see with repeated returns, no transportation has occurred within the root canal system. This is a case done by one of the graduate students at Baylor University a few years ago utilizing the profile system. As you can see, the tooth had a pretty severe mid-root curvature, and the student mentioned that he had a difficult time preparing it. This is an animation of the sequence of instruments he used. The orifice shaper 40, followed by the orifice shaper 50, and then followed by the orifice shaper 30 to flare the orifice. He then inserted a number 2506 taper into the root canal and proceeded apically with great difficulty to this point, followed by a 2006 taper that he anticipated getting to the apex with, but was unable to do. He determined the working length utilizing a 10 hand file.
He came back with a 2504 taper, which is a smaller taper but a larger apical size. This allows the instrument to cut only with the tip of the instrument, not with a blade. He followed with a 2004 taper, which again allowed for only cutting with the tip of the instrument. The blade was free to rotate without contact with the walls. The next instrument was a 2504 taper, which meant that this instrument was cutting only in the last millimeter of the tip, finally finishing off with a 2506 taper, which basically allowed the instrument to create a 25 apical preparation with an 06 taper from orifice to apex, and then obturated the root canal system. The mesial canals joined, and you can see he was able to produce a tapered funnel-form preparation from orifice to apex. He talked about the canal being very difficult to prepare. Anytime an instrument will not advance into the root canal system, you basically have four things that are occurring. One, the canal size and the instrument size are inappropriate. In other words, you're using too large of an instrument for that particular canal. There is debris within the root canal system impeding you from advancing further, or there is torque exerted on the instrument because of severe mid-root curvature. Or you are in the apical area, and if the instrument does not advance, this is telling you there may be abrupt apical curvature that you did not anticipate, and you need to remove your rotary nickel titanium instrument and explore the canal with a hand instrument. Now I've gone through the sequence that the manufacturer recommends that you use clinically. I want to show you a clinical case. This is an upper first molar. You can tell very little about the length or the canal curvature or diameter from the radiograph, but you can see the canals present, so you're not dealing with a severely calcified case. I recommend to all clinicians to use a glide path file, a number 15 file inserted into the root canal system, and however far it advances, to take your rotary instrumentation to that point, and this widens the orifice, and then you can scout it again further apically. As a clinician who has done tens of thousands of cases, I don't do that routinely myself, so you won't see that in this clinical case. Open up into the chamber, and you can see in this particular case there is a slit there from the mesial buccal running palatally. This generally indicates an MB2 is present. Irrigate after each instrument. In some of the editing of this particular video, I edited out the irrigation, but I generally did irrigate after each instrument. You can see the orifices of the canal. I prefer to enter the canal with a number 2504 taper. This allows me to go to the point where a number 15 hand O2 taper instrument will generally go while you are establishing a glide path. I take it in, I tilt the contrangle, and put pressure against the blade in every direction, not just straight in and out, but by tilting the contrangle, you can rake in a buccal direction, lingual direction, or distally to try and straighten the orifice a little bit. As you can see, as the instrument rotates, it brings pulp tissue up and out of the root canal. I do not put excessive forces on the instrument. I just go in, and it's been stated many times by other operators, with basically the same amount of pressure you would use while writing with a number 2 lead pencil. You can see in the groove that I've actually found 3 orifices, and you can see rotation in that center groove that has already been instrumented a few millimeters, tissue moving, so that you know that these other 2 orifices join. I generally try and take the 2504 taper halfway to 2/3 the way down my estimated length, because I don't determine working length until I've prepared most of the root canal system. You can see how effective it is at removing pulp tissue out of these canals. Here is almost the entire pulp coming from the palatal canal. I now followed with a 30-04 taper that logically would tell you that it would go about 1 millimeter short of the 25-04 taper. In most cases, you will actually go to the same depth or very close to it. All I'm doing is opening the orifice a little bit without using orifice shapers or Gates-Glidden drills. Again, I am forcing this blade against the various walls of the root canal, almost in a circumferential filing motion as it is rotating to straighten the canal orifices slightly.